Today we are going to discuss an important topic, that is the respiratory distress in newborn. So we must know about the causes, what are the causes, how we will manage, what is the importance of the history. So it is a very important topic, the respiratory distress in newborn. Respiratory distress is encountered frequently in newborn. Respiratory distress in newborn may be potentially life-threatening condition. The key to successful management includes a complete maternal and newborn history, perform thorough physical examination, recognize the common respiratory disorders, differentiate among various diagnostic entities, and identify those that are life-threatening. Respiratory distress in newborn is characterized by one or more of the following. So baby may present with nasal flaring, chest retraction, tachypnea, grunting. These are the sounds which you can audible. It is a sign of the distress. So if you notice any one sign from this, you may recognize that baby having respiratory distress. But some babies and infants who has an advanced degree of respiratory distress may exhibit additional signs. Cyanosis, bluish discoloration of the lip, tip of the nose, ears, extremities, gasping condition, very difficulty in the respiration, patient may gasp, baby having the gasping condition, choking, apnea. Apnea means the cessation of the breath more than 20 seconds, and stridors. So these all are the signs of the respiratory distress in newborns. So how you will assess the initial assessment? The aim of the initial assessment of the infant and respiratory distress is to identify life-threatening conditions that require prompt support. So if you assess the child having tachypnea, cyanosis, stridor, gasping, nasal flaring, grunting sounds, so it is an alarming sign and it requires prompt support. The alarming sign of life-threatening conditions are obstructive airway, gasping, choking, stridor, insufficient breathing, apnea, or poor respiratory efforts. Patient may be in the sign of the circulatory collapse, bradycardia, hypotension, poor perfusion, poor oxygenation, cyanosis. Okay. So if you will check the capillary refill, it is a delayed, patient become cold, become hypothermia, and patient may have a skin changes of the underlying pathology. So you assess patient thoroughly and take a proper history, because on the basis of the history, if you have a good history, you will reach and the diagnose up to 85%. So the result of fetal assessment during pregnancy, you may take for the screening like ultrasonography, biophysical profiles, triple screen to see any congenital anomalies, and fetal monitoring during labor and delivery to assess for the fetal distress. So see the fetal heart sound rate, beat to beat variability, presence of declarations in heart rate, and look for the complication at the delivery, like birth trauma, the presence of the meconium, the perinatal depression. So the maternal and obstruct conditions associate with respiratory distress in neonate. If we assess the obstructive conditions, The use of anesthesia. Previously, the anesthesia given GA, general anesthesia. It caused the central depression and respiratory depression in the neonates. Hydrops fetals causes the pleural effusions. The premature delivery, those baby who born premature, they have respiratory distress due to the hyaline membrane disease. The chronic, the chorioamnionitis, and which the history of the fever and all these things, and it leads to the neonatal sepsis, the pneumonia, and if prolonged rupture of the amniotic fluids causes the meconium or meconium stent, amniotic fluids causes the Meconium Aspiration syndrome. It is chemical pneumonitis which causes the pneumonia in the children and the respiratory problems. And antepartum hemorrhage causes the anemia or hypovolemia. If we take a history of mothers drug abusers or drug withdrawal, it is important because both have an impact on the newborn neonates. If mother suffering from diabetes mellitus, baby may suffer from hyaline membrane disease, the hypoglycemia, polycythemia, cardiomyopathy, or any other congenital anomalies may be associated with this. And if patient having history of infection, then mother having history of fever and last trimester, baby may develop pneumonia, sepsis. So the history is important. You look for the maternal conditions that are associated with the respiratory distress. Details of the presenting respiratory symptoms, a history of coughing and choking in relation to the feeding. Mother gave the typical history of the choking while the baby feeding. Okay, the maternal history of the polyhydramnios and choking after feeding, congenital history of the recurrent emesis, the gradual improving symptoms or gradual deterioration. So to look at the condition whether it's improving or the deteriorating. Sometimes baby may have a frothy secretion from the mouth, and baby may choke. Patient have congenital tracheoesophageal fistula and other congenital anomalies. So look the physical examination. And if we look at the newborn, the first exams, it's mostly top to toe and front to back. You have to assess everything to see any abnormalities. But as the perspective of the respiratory distress, you must do the inspection. And inspection, you look for the cyanosis, for respiratory retractions, the chest and drawing, the apnea, inspiratory stridor, the asymmetric chest movements, the shape of the abdomen, whether it is scaphoid or whatever the shape, you must explain it. Then do the auscultations, the symmetry and adequate of symmetry and adequacy of the air exchange, abnormal breath sounds, the heart murmur, the trans-elimination test. These are the important for the auscultations. The heart murmur is also important because, as we know, sometimes the respiratory auscultation are the fine, but patient may have congenital cardiac problem, congenital cardiac disease, which can associate, which can trigger the respiratory distress. So what are the differential diagnosis? If patient having respiratory distress, what should be the differential diagnosis? What is in your approach? What DD in your mind? So you should think about the parenchymal lung disease, the pneumonia, surfactant deficiencies. You know that surfactant deficiency occurs in the hyaline membrane disease, and it is more common in the premature babies. We will discuss it in detail later on. Congenital heart disease, and congenital heart disease further divides into the two groups, whether it is a acyanotic congenital heart disease or cyanotic congenital heart disease. Check for the neurological disorders, baby having seizures, asphyxia, sign of meningitis, And you always think about the metabolic causes, the hypoglycemia and acidosis, hypothermia, sepsis, acidosis, polycythemia or anemia. These are also the differentials. Airway and chest wall deformities as well as abnormalities of the diaphragm and the mediastinal structure. So one condition is known as TTN, that is a transient tachypnea of newborn. And this condition mostly occurs in cesarean sections. When baby born with the C-sections, after 3 to 4 hours, patient develop the tachypnea, the respiratory distress, and it will resolve within a few days, a few hours, but it occurs in the babies who born with the C-section, because in normal birth, when baby goes through the vaginal birth, baby squeeze the all fluids which remains inside the lung, it is squeezed out through the oral cavity and lung become clear. But in TTN, baby is not going through this natural process and baby having a fluid inside the lungs, and this causes the transient tachypnea. So this is the basic pathology why this happens. So the TTN represents the transient pulmonary edema resulting from delayed clearance of the fetal liquid. It can also occur in both preterm and term babies, and seen in a baby delivered by the C-section. So if BCQ come to you, the TTN occurs in normal vaginal birth or TTN occurs in the babies who born through C-section. So the correct answer is through C-section. So what are the clinical presentation? As I told you earlier, that will be having a respiratory distress, the tachypnea, fast breathing, patient have grunting, nasal flaring immediately after birth. At the time of the birth, baby is okay, but after a few hours, baby become tachypnea, having a respiratory tachypnea, grunting. And if you will do the X-ray test, it shows increased interstitial marking and associate fluid in the interlobular fissure. So the fluid in fissure is a diagnostic radiological marker of the transient tachypnea of the newborn. And if you will do the ABGs, the arterial blood gases reveals respiratory acidosis and mild to moderate hypoxemia. So TTN is generally a benign, self-limited disease. It is a benign, self-limited disease. You just give the oxygen therapy to the baby. If baby is in tachypneic respiratory distress, you keep the NPO for little while till the respiratory rate turns towards the normal and check the oxygen saturations. And sometime baby may require the mechanical ventilations or ventilator supports. But usually this condition is self-limiting and it resolves within 2 to 5 days. And usually the full recovery is expected in this condition. So the brief nutshell of the TTN, it is a benign self-limited disease. It occurs in the baby born through C-sections. And usually if you check the radiology X-ray test, it shows fluid in fissures and mostly requires the oxygen therapy, and baby will respond to the oxygen and full recovery is expected within 2 to 5 days. So if you look at this radiology, here is a fissure, fluid in the fissure on the both sides. Otherwise, lung marking seems to be the normal, the cardiac shadow seems to be the normal. So this is a diagnostic for the TTN. fluid in fissures and radiology. One important topic is Meconium Aspiration syndrome. It is one of the common cause of the respiratory distress in the newborn. And Meconium aspiration usually occurs in the post dates. If a baby born after 42 week of gestation, even sometime in the prolonged labor in the normal babies, you may observe the Meconium aspirations. Okay. So if a baby born before 37 week of gestation, it is known as a preterm. If baby born between the 37 up to 42, is to the normal gestational. And if after 42 week, it is a post-term. Okay, and Meconium aspiration is mostly occurs in the post-term. And those baby who born before the 37 week of gestation, they have hyaline membrane disease. Okay, we will discuss it. So the Meconium staining of the amniotic fluid occurs in approximately 10 to 26% of all deliveries, and seen almost exclusively in term and post-term deliveries. Passage of Meconium in utero may represent fetal hypoxia. Meconium can be aspirated before, during, and after delivery. Once aspirated, Meconium can cause obstruction of the airway passage. It causes the chemical pneumonitis with activation of several inflammatory mediators and inactivation of the lung surfactant. So, what are the presentation? Varying degree of the respiratory distress. The chest may bulge and it shows the barrel chest. Audible rails and auscultations. The chest radiographs usually shows patchy areas of atelectasis, alternating with areas of overinflation. Lung may be hyperinflated. Okay, pneumothoracic is seen in 10 to 20% of infants who have a Meconium aspiration syndrome. So, one of the known complications of the Meconium aspiration syndrome is pneumothoracic. So these are the patchy infiltration inside the lung. You have seen this in case of the Meconium aspirations and hyperinflated lung. Highline membrane disease, known as RDS, and most common condition in a preterm infants. So the preterm infants more prone to develop hyaline membrane disease. Post-term baby, post-date baby is more prone to develop Meconium aspiration. C-sections more prone to develop the TTN. Okay, so the cause is insufficient pulmonary surfactant produced by type 2 pneumocytes. It reduces the surface tension inside the alveoli, preventing them from the collapsing. So if BCQ come to you, the surfactant is produced by type 1 pneumocytes or type 2. The correct answer is type 2 pneumocytes. Okay. The blood gas typically reveals hypoxemia and respiratory acidosis. The X-ray chest lung demonstrates the typical ground glass appearance and air bronchoground. So if you will do the radiology or the X-ray of chest, it shows the ground glass appearance. Absolutely the white, hazy, and no blackish lung seen, mostly to the haziness. If it presents, it is a typical presentation of the hyaline membrane disease. You must take a prompt actions. You should give the surfactant to the baby, and mostly baby recovers if you will treat accordingly. So look at this. I have shown the previous X-ray. You should compare this X-ray with these. This is haziness, the ground glass appearance, and typical presentation of the hyaline membrane disease. So this is a radiology of the hyaline membrane disease. How we will prevent of this condition like a Highline membrane disease? To continue gestation and treatment with the antenatal steroids. Give the steroids to the mother prior to the delivery. If you will give the too short, mostly it causes the lung maturity in newborn. Okay, so affected infants often are managed with mechanical ventilation and endotracheal surfactant replacement therapy. So you pass the ETT cape on the mechanical ventilation and give the surfactant through ETT tube. The use of continuous positive pressure is less invasive alternative. You can give the positive pressure ventilation to the baby, and baby will respond if you will treat promptly. And the definite treatment is by giving surfactant to the through endotracheal tube. If a mother is there are many chances, or if any problem with the mothers like preeclampsia and all these conditions, you can give the steroid to the mothers. And if baby's mother is okay, try to continue the complete gestation. As baby born with the normal gestational term baby, the chance of Highline membrane disease is minimized or less, because a pneumocyte type 2 can produce the surfactant, and there will be no surfactant deficiencies. Congenital pneumonia, aspiration pneumonia. So there are certain variant of the pneumonia, and it is one of the common cause of the respiratory distress. And mostly the pneumonia is the leading cause of death under 5. So what is the most common cause of death in children under 5 years? The correct answer is pneumonia. Okay. So the most common infection in neonates can be due to different antenatal, perinatal, and postnatal causes. So pneumonia can present with a diversity of signs, and infancy includes any form of respiratory distress, lethargy, poor feeding, jaundice, apnea, temperature instabilities. So you will go for the labs, and you can send the CBC, complete blood counts, the blood cultures, CRP, C-reactive proteins, X-ray chest. Okay, and if you will check at the X-ray chest, it shows the bilateral consolidation, the patchy involvement. Here, the modality of treatment is quite different. If you suspect pneumonia, you will give antibiotics. So the treat respiratory distress with antibiotic until pneumonia is ruled out. So the antibiotic is a main antibiotic has a main role of main role in the treatment of pneumonia. Okay, so you should give the antibiotic. And if children is less than 2 months, or fresh newborn baby, you will give parenteral and will give through IV antibiotic. Other causes of the respiratory distress in newborn or neonates is congenital heart disease. So we discussed earlier the respiratory causes. Now we at least know what are the congenital heart causes, heart diseases which causes the respiratory distress, and how we will differentiate the respiratory distress due to the lungs or to the respiratory distress due to the congenital heart disease. So the important to differentiate from pneumonia, the two can coexist. Sometimes both pathology can occur on the same time. The presence of murmur does not exclude pneumonia. The meconium staining of amniotic fluid does not rule out the congenital heart disease. So both conditions coexist. Okay, so we should do the examinations and treat promptly, and we must keep in mind the cardiac causes, the pulmonary causes, and if we only treat the pulmonary or lung cause and we ignore the cardiac, patient baby may having any congenital heart problem, which might be missed. So signs that generally are consistent with congenital heart disease: the visible hyperactive pericardial impulse, the gallop rhythm, the poor capillary refill, the weak pulse, decreased or delayed pulse in lower extremities, hepatomegaly. So these are the differential of the congenital heart disease from pulmonary disease. In congenital heart disease, history is important. Sometimes previous sibling having congenital heart problems. Prenatal echocardiography is helpful. And finding other cyanosis, the gallop sound, the split second heart sound, the large liver, mild respiratory distress, and how we will differentiate the cyanosis of the cardiac cause and cyanosis of the lung or pulmonary cause. The cyanosis of the cardiac cause usually does not diminish with the oxygen supplement, okay, and the cyanosis of the pulmonary cause mostly give the response to the oxygen. So the maternal pulmonary cause में maternal fever, the meconium stand, baby meconium stand, premature deliveries, okay, and baby having severe respiratory rate tachypnea, single heart sounds, patient having fever and cyanosis. If we check the chest radiograph, it is normal in case of the pulmonary causes, but the heart size is abnormal in case of the cardiac cause. Because cardiology, congenital heart disease, heart shape should be different. Egg and stick, it could be a boat shape, it could be any time, and cardiomyopathy is the large heart, okay, and decreased pulmonary vascularity. And in case of the lung pathology, there's an abnormal parenchyma, but the size is normal in case of the pulmonary cause. If we will do the ABGs, the partial pressure of the oxygen is decreased, okay, and normal or decreased PCO2. But in case of pulmonary cause, the PO2 is decreased, but PCO2 is increased. So this is how we will differentiate on ABGs, the cardiac versus pulmonary cause. Hypoxia test, simply if we give the oxygens and patient give the response, okay, and the PO2 is increased in case of the pulmonary cause, but PO2 is not increased in case of the congenital heart disease. Echocardiography shows the abnormal heart and vessels. It is one of the diagnostic tool for the congenital heart disease. Okay, the heart size is normal and vessels are normal, echo is normal in case of the pulmonary cause. So thank you very much for listening for your kind attention. So the respiratory distress in newborn is a vast topic. We must do the thorough clinical examination, take a proper antenatal history. You must do the clinical examination and look at for the cyanosis, look for the respiratory distress, retraction, striders, and all these things. And you can manage accordingly. If baby is premature, baby may have a problem like Highline membrane disease. If baby delivers through the C-section, baby may develop the transient tachypnea of the newborn, that's DTN. If patient is Meconium stand, having barrel-shaped chest, tachypnea, grunting, your diagnosis, Meconium aspiration. Okay, if baby is not responding, oxygen saturation is not improved with the oxygen, and patient may have a murmur. X-ray just shows the cardiomegaly or abnormal shape heart. You think about the congenital heart disease problems. Okay, and the congenital heart disease further divides into the two groups. One is the congenital cyanotic heart disease, and other is the congenital acyanotic heart disease. Okay, and you treat the cause accordingly. And in some time, baby may have congenital Yeah, that's we maybe have aspiration pneumonia. Okay, so the pneumonia is one of the leading cause of death under 5. So if patient having a real strong crepitations all over the chest and this thing, you treat as a pneumonia. So treatment modalities is quite simple. In case of the Highline membrane disease, you give the mechanical ventilation, admit in nursery or an ICU, give oxygenation, give surfactant therapy. In case of the pneumonia, you have to give the antibiotic. If patient is in hypoxia, you can give the oxygen supplement, continue positive pressure ventilation, or patient is in ABG is deteriorating, you can go through the mechanical ventilation or ventilator support. Okay, if baby having a congenital heart disease, you can treat accordingly, and uh, you can have receive the help from the cardiologic cardiology and all this for their valuable input as well. So thank you very much. This is all about the respiratory distress in children. Thanks. If you have query or question, you can email me or you can send to the moderator. He will communicate with me. Okay, so thank you very much.